Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent from developing and improve from suffering with brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a physician and Chief Scientific Wellness Officer at Kemper Cognitive Wellness, and I'll be your guide on these sound waves. So whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have a loved one with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's, dementia, and just generally things in life's second half. If you have questions or comments, check us out on social media. To support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show if you find these episodes valuable. That's Patreon, Patreon, patreon.com/evolvingpast. So here we go. Let's get better. Welcome back. This week we have another wonderful guest who's become sort of an old friend of mine. This is Dr. Kristine Lokken. She's a functional neuropsychologist with a passion for helping people restore brain health. Her extensive background in clinical research, medical neuropsychology, and holistic wellness merged together to create the Brain Health Institute, BHI. In addition to her work at BHI, she is currently the director of the Rehabilitation Neuropsychology Service at the Birmingham VA Medical Center and serves as a clinical assistant professor at University of Alabama at Birmingham. She has maintained a private practice for over 15 years and has seen thousands of patients with varying neuropsychological and psychological issues in her clinical work. Dr. Lokken has published several articles in peer-reviewed journals and has lectured extensively on brain health. Welcome, Dr. Lokken.
Thank you. I'm so glad that we were able to connect.
Yeah, I'm glad. I recall when we first met, we had dinner together, a training, and we became conference friends. Like you have your conference friends, your conference tribe. You're like one of my conference friends, and I cherish that. So thank you very much for spending the time with us on the podcast.
Yeah, thank you. I know, and I was just recently at a conference and I missed you. So yeah, so hopefully we'll connect some more on future conferences.
Yeah, you were telling me, so you were actually at 2 conferences, and that may be an interesting place to start. So first of all, you are a neuropsychologist.
I am.
Professionally. And if you can you just briefly explain what that is and what the difference between that is and a regular psychologist maybe?
Yeah, so a neuropsychologist is also a regular psychologist. So you receive training as a generalist, as a clinical psychologist, and then you typically pick a track where you pursue specialty training in the neurosciences, brain behavior, relationships, and neuropsychologists are specifically poised to provide excellent differential diagnosis of people who have different brain injuries or differential diagnosis in terms of dementia. And so we just specialize a lot more in terms of brain behavior relationships.
So when I think of a neuropsychologist, at least in much of my professional experience, it's somebody who is doing an assessment, usually with some of the testing that I'm sure we'll talk about, and is providing an opinion, but is usually not following up, doing treatments, things of that nature. They're assessing for something like ADHD, a learning disability, traumatic brain injury, dementia, as you mentioned, Alzheimer's, etc. But I don't think of those people usually as doing the work of helping people get better. Is that accurate in a general sense, or is that completely inaccurate?
No, it's accurate in a general sense. And I think that's really conventional neuropsychology. And conventional neuropsychology, you get your PhD. So typically you do a lot of research on one specific area. And so typically you're informing the research, you're really diving in deep into how to differentially diagnose and doing that clinical assessment. But I think in the words of Dr. Perlmutter, neuropsychologists are similar to neurologists, where it's really diagnose and adios. And in my career, I started becoming really uncomfortable with that and was a little bit thought it was unusual that my colleagues didn't feel as uncomfortable with that. And so I also have more of a personal passion for health and wellness, and also pursued training in health psychology, and have just always felt that health behaviors matter. And so now more research is coming out where we can really see how health behaviors also affect the brain. I think for a while we were thinking that we could see how it could affect cardiovascular health or, our digestive health, things like that. But it was like the brain was somehow insulated from that or wouldn't be affected by our health behaviors. And so I'm thrilled that we are now finding our health behaviors really do affect our brain health. And I feel that, I've been really able to kind of meet that nexus between neuropsychology and then the interventions that we can do from a health behavior perspective to help with those individuals affected by brain issues.
So that's interesting, because before we started recording, you were telling me about the two conferences you were recently at in New York City. And one was a traditional, very large gathering of neuropsychologists, as I understand it. And the other was the Integrative Health Symposium, right?
Yeah.
And I don't know how many people were shuttling back and forth between both, but I can't imagine that there were a lot.
I think there was one.
One.
And that would be me. It takes a lot for me to decide to go to a conference, although the International Neuro Society is the big neuropsych conference, and it's where all the new, hot, innovative research in neuropsychology is coming out. And so it used to be a meeting that I went to every single year, but I haven't been there in about 5 to 8 years. And then the IHS, the Integrative Health Symposium, was at the exact same time, the exact same place in New York City and 4 blocks away from each other. So I decided to submit research to both of the conferences, and both of the research proposals got accepted at each of the conferences. And so I ended up going. And yeah, it was really striking to me that there are whispers of functional medicine and biomarkers of Alzheimer's disease and other dementias, at the International Neuropsych Society, but yet no one's really taking that a step farther. And then you go over to Integrative Health Symposium, and they're talking more about using functional medicine in the treatment of Alzheimer's disease and other dementias, but yet not really being able to thoroughly assess and diagnose neurological disorders.
Yeah. Any of the topics, especially early recognition of Alzheimer's and dementia, especially from the neuropsychologist side, as you know, and maybe you can explain it, but in a simplified understanding, in my mind, we don't have a lot of great tools to identify really early signs of memory problems, or what might be in 5 or 8 years or longer, maybe 15 years, Alzheimer's. From your perspective, why is that? Is there anything coming down the pipeline that seems promising? But I know it's early diagnosis, because we'll get into the treatment in a little while. But what are the issues with sorting out problems with cognitive impairment, even at the very early stages, from a neuropsychologist standpoint?
Yeah, in terms of cognitive testing, I think we are better able to really identify cognitive impairment early on than we've given ourselves credit for. Because I think that in terms of using a neuropsychological battery of tests, typically where people were still performing within the average range, many times a conventional neuropsychologist it would say there's really no impairment here until there's true impairment. Whereas you can still kind of see the smoke before the fire. So for example, if an individual is a highly intelligent individual, their IQ is in the high average range, but then their processing speed is at the lower end of the average range. And some of the hallmark tests that we use to predict dementia, such as animal fluency or semantic fluency, is, falling below where we would expect it to be, I think we're able to really pick up on that subjective cognitive impairment really early on, 10 to 15 years prior to the real symptoms of a dementia starting. And so I think as neuropsychologists, becoming confident with that identification and being able to choose a battery of very sensitive and specific tests for that early identification.
What are the best tests, if you will, or domains to test that specifically identify some of the early signs as opposed to the later stages when people are obviously very impaired?
Yeah, I think we do want to have a global cognitive marker, so something like the MoCA which is the Montreal Cognitive Assessment. I think many people are familiar with that. Or I use something from the Wechsler Memory Scale, which is the Brief Cognitive Status Evaluation. So it kind of gives you a global cognitive marker where it tests a lot of different domains and puts that together in an algorithm and gives you a total score. But then we do know from years of research in terms of differential diagnosis that there are a couple of hallmark issues that come up in early identification of Alzheimer's disease. And one is rapid forgetting. And so you would really want to do a nonverbal memory test, one that's going to do a learning curve and then also immediate memory and then a delayed memory. And that delayed memory should be more like a 30-minute delayed or at least a 20-minute delayed. And then also the verbal memory, again, looking at your learning curve and immediate memory, and then a delayed recall of up, more than 15 minutes, like more like 20 minutes or 30 minutes in terms of that. We also want to look at the difference between semantic fluency and phonemic fluency.
Well, can you explain those terms?
Yeah, it's really kind of interesting that it's really mediated by two different areas of the brain. And so phonemic verbal fluency is like a childhood test where you say, hey, I'm going to give you a letter of the alphabet and tell me as many words as you can think of in the next minute that start with that letter. And so the person would say, bake, boy, ball, bat. And over the next minute, you measure that, and then you measure a different letter, and you look at their performance with that and compare it to normative data of people of their same age, their same gender, their same education, their same race, and see where they fall with that. Now, that is going to be mediated by the frontal lobe. And then for semantic fluency, one of the test that's typically used for that is animal fluency. And so you say to a person, tell me as many animals as you can think of in the next minute. And so the person comes up with all these different animals. And that the semantic fluency, what we found is actually mediated by the temporal lobes. And so if there's a discrepancy between phonemic verbal fluency, which is mediated by the frontal lobes, and the semantic verbal fluency, where the semantic is significantly worse than phonemic, we know that that's more of a hallmark for an earlier sign of Alzheimer's disease, as it's mediated by the structures that are more involved with that process. And so that's one thing that is, pretty quick and dirty, easy test to do. That's pretty standard in terms of something that's included in a neuropsychological evaluation. And then we also want to look at processing speed and executive functions, which are more of the higher order thinking, like problem solving, mental flexibility, and those types of cognitive characteristics that are typically thought of as uniquely human and mediated by the frontal lobe.
So to broaden that, and thank you, that was clear. I sit as an internist geriatrician by training, and you sit as a neuropsychologist by training, but we're also both intervening with people that come to see us, meaning we're trying to do treatments. And I think that it is important to reemphasize that as a neuropsychologist, that is unique. Your approach is unique, and we'll get to that. But still now on the diagnosis side, meaning I'm trying to describe what is in front of me, like what are the issues that we can quantify or measure in the person that's sitting there saying that I think I have a problem, or I'm not sure if I have a problem, but my mom had a problem and I want to know if I'm going to have the problem. Other than neuropsychologic tests, that you mentioned, are there other things that you feel are important, especially those that may give you more information and more context for what you're seeing in the neuropsych testing, such as an MRI or a QEEG or lab sets or anything? What do you feel is sort of like an important array of tests to be done for someone on a basic level that's coming in and saying, I have a problem. I'm not sure what it is, but I really think there's an issue.
Yeah, I think marrying the cognitive assessment with measures of specific biomarkers. And I think it is important to look at APOE status, if nothing else, just to tell us that person's relative risk and to let us know how vigilant that person needs to be in terms of intervention and whether or not it kind of raises a red flag in terms of what might be happening with that person. What we're looking at the Brain Health Institute is really trying to distill down which biomarkers are really going to be most effective in terms of that early identification and in terms of what's going to give us a little bit of protection in terms of preventing or restoring or stabilizing cognitive decline. And so one of the posters that we presented at the International Neuropsych Society was on looking at our biomarkers and their correlations with cognitive testing. And one of the biomarkers that was correlated with pretty much every single neurocognitive test, so not only with global cognitive function, but also with visual processing, also with processing speed, also with executive functions, also with verbal fluency, also with memory, was homocysteine. And so the higher the homocysteine level, the lower the neurocognitive performance was across the board. And I found that pretty interesting. I mean, that seems like it's an inexpensive biomarker, unlike some of the other ones where it can be pretty pricey to get like DLA, DRDQ, and stuff like that. But for homocysteine, it seems like it's something that could be measured fairly early on, even in, very early on in terms of 20s and 30s, and just making sure that people are keeping the homocysteine in a really low range. I think Bredesen recommends even below 7. And thinking about like a biomarker such as that, which could be predictive of cognitive decline.
So the homocysteine is interesting. So did you see a linear relationship? In other words, the higher the homocysteine, the worse the cognitive scores were? Or was it just sort of once somebody's at a 12, a 13, or some number, or tertile or something like that, that they were in a batch or a bin that was worse? Once there's a threshold that's crossed, then you see the worst cognition? Or is it more the higher it gets, the worse the cognition seems to be?
It looked like more of a linear relationship. Yeah, which is interesting because some of we just lumped all the data together and then did correlations, and some of our patients had normal level of homocysteine and some high, but it looked like a very linear relationship between them.
So fascinating. Any other labs, biomarkers that you're seeing that are important, that maybe were surprising to you, at least maybe in the amount that they matter, as you might have been doing it for a long time but not realized, like homocysteine, you may not have realized, wow, there is this very strong apparent correlation.
Yeah, the other ones that were falling out in terms of neurocognitive impairment were fasting insulin, which isn't that surprising in HbA1c. And as we know through much of the work that's done, that Alzheimer's can be considered a diabetes type 3 of the brain. And so it really does matter in terms of the level of fasting insulin or HbA1c. So the higher that was, the worse executive function performance was and verbal fluency performance. And then we also saw a correlation between GGT and some of the cognitive scores.
What do you think that's about, GGT and the cognitive scores?
I guess if you look at some of Pizzorno's research, he sometimes will use GGT as a crude measure of toxin load in the body.
Yeah.
So that might be one of the explanations for that.
Do you think histories support when, in other words, when this blood level called GGT is elevated, and some literature would say that there's problems with liver clearance or toxicity, as it were, does that then, when you dig into someone's story, their history, is it supported by their story? Or is it just, wow, why is the GGT high? I have no idea. This person has lived a pristine life in the suburbs with no pesticide exposure or something like that. Or is there oftentimes finding something from the story that, oh yeah, that makes sense that the GGT is elevated?
Yeah, I would have to say anecdotally, it does seem like the stories are supportive. Typically, it could be military veteran who had, many different types of exposures, or someone with heavy metals. So I think we need a lot more research to really delve into that. But as you know, typically those that are presenting with cognitive impairment, as you dig back into their history, there's typically some toxins that they've been exposed to and that put them at a higher risk.
Yeah, absolutely. Absolutely. And then I guess the follow-up question on that is, for people that don't have so much brain damage and impairment that it's unlikely that they will improve, do you find that when you're identifying GGT is elevated or there's a story of toxicity, that when you treat that, people improve?
I wouldn't say it was a direct relationship. Are you finding that in your practice?
Yeah, so that's an open question for me.
Yeah.
I think a lot of people are talking about that, but I don't see strong evidence for it. I have had my own patients that are one-offs, anecdotes that have improved, but I would say as a rule, I haven't seen that to be true yet. But it's still early in the day, it's still early in the day, this stuff. So the conversations and the investigation is probably the most important thing to me.
Yeah, I think so too. And it's early in the day, and the people that we have treated that way have been late in the game. And when we first started doing more of the Bredesen protocol, those who tested high for heavy metals, we would jump on that and start with a detox protocol. But I'm not sure that was the appropriate way to start, because they didn't seem to get dramatically better even when the heavy metal loads were coming down. And so now that we've been doing it for a while, I think you really have to start with the fundamentals with everyone and work your way up the chain. And so, first of all, you have to open up the detox pathways and make sure that the body is able to clear the toxins or the heavy metals. You have to clean up the diet, clean up the gut, give nutritional support through food, lower inflammation through supplements and through the food that we eat. And even, looking more into like some of the fasting literature, going that route, and then starting to work on sleep and behavior and things like that. I think the more and more that I start to delve deeper into this, you just have to get back to basics first, rather than diving into complicated medical interventions or fancy technology.
Yeah, I couldn't agree more. Mostly because so many people respond to the basics,
Yeah.
Food and movement and awareness of stress, and then, a few things to do about it. And then I would add to that also assessing oxygen, sleep.
Yes, sleep.
Which I know very, very, very lot about. Going back for a second to the assessments. So most of us are not neuropsychologists, so we have not been trained to do neuropsychologic testing. And frankly, at least here in Cleveland, it can be difficult to get a timely appointment with a neuropsychologist. People may need to wait 3, 6+ months just to be seen. And that may not be unique just to neuropsychologists, but I would say neuropsychologists are among those professionals there's just not that many of them, and especially not that many that are trained, let's say, on the dementia side, on the picking up problems of cognitive impairment. So the alternative solution for many people, and some community-based neurologists as well, are online cognitive tests, things like CNS vital signs or Cognivue or Cognostat. Do you have an opinion about these sorts of tests that can be delivered through a computer interface where it doesn't require a clinician or may not require your level of expertise, but rather just a technician to administer the test or something like that?
Yeah, I think there's a lot of online testing resources that are coming available. And there are several, such as CNS vital signs, that are showing to have good reliability, good validity. And I think in the absence of the availability of doing a full neuropsychological evaluation, they can serve a purpose. They can serve as a screening instrument. And as with CNS vital signs, they do test the different cognitive domains, so verbal and visual memory. They test processing speed. They have a couple of executive functioning tests like the Stroop test and tests of shifting attention, and a test of divided attention. So they're fairly thorough, and they do take a tour of the brain as we would with a neuropsychological assessment. I think it's just important to keep in mind the limitations of them in terms of they can't be diagnostic. It can be more of a screening tool. And even though they do have embedded measures of effort and malingering, I think that it's difficult, especially if the patients are taking them at home, or in terms of like the MoCA printing them off and taking it like a partner giving it to the other one. I think there is a little bit in terms of the ecological validity that needs to become in question. But in the absence of being able to get a convenient or timely appointment, I think they can be very useful for monitoring over time and giving you a good, foundation for maybe what is going on with that person.
Yeah. So neuropsychologist best?
Well, yeah. And clearly I'm biased, but I'm often just completely floored at the sensitivity and specificity of the neuropsychological tests that we give.
Can you explain those two terms, though, for the non-statisticians amongst us? Just a general explanation of the idea of sensitivity and specificity without the math, the intuitive statistic.
Right, exactly. So sensitive is just that, is it sensitive to pick up, what it is supposed to pick up? And is it specific enough to identify what it's supposed to identify? And so I guess that's, in a very general sense, what you're looking for, rather than just more of a screener saying that something might be going on, but it could be depression causing the memory impairment, or it could be anxiety, or it could be that the person didn't understand the test instructions, or it could be that, they were confused, or they're not computer savvy. And so we do know that the neuropsychological tests have been tried and true over many years. There's one that's really completely interesting to me, where it's a word list where you learn the word list over 5 trials. And then we do recall, a short-term delay recall, and then a long-term delay recall. And then at the end, there's a forced choice test to pick up on whether that person was giving full effort. And I do a lot of forensic work. And so malingering sometimes will come up there, or might come up in...
Malingering meaning like faking?
Faking, yeah, or just really not giving full effort.
Okay.
And it's really interesting that forced choice test at the end will pick up on whether or not that person was malingering. And so a patient who's malingering will fail that part of it, and they'll just, be kind of less than 50th percentile, or just kind of random guessing on that. And yet an Alzheimer's patient who doesn't even remember that you read them a list will get 100% on that forced choice part. And so it's just really interesting to me that it holds up every single time. And my research assistant, who was just learning the test, like, she was just floored by how this woman with Alzheimer's disease didn't even really recall her having read that. And then she aced the forced choice portion of the test.
Yeah, it's amazing how many people have trained with me, or they're seeing a MoCA, the Montreal Cognitive Assessment, some of these screening tests that are not the full neuropsych test, but for the first time when they're in our office. And they'll be conversing with someone who will be fairly far along in terms of dementia, meaning fully demented, and somebody that's unable to live by themselves independently anymore, and can carry on a conversation for a good 2, 3, 4 minutes, and you really wouldn't know anything in the course of a normal interview. And then you get down and just some of these screening tests, and you see why they're fairly well designed, because it's hard to fake those things. So it is interesting. We start to work with the tests.
Yeah.
On that note, the context, the setting of testing, I have two incidences I'd like to share with you. The first one was, I remember when I was in my geriatrics fellowship, and I spent a couple weeks with some neuropsychologists and neurodegenerative disease specialists, neurologists, and I was watching the operation and an observership, some service work there. And I remember seeing this guy who had a learning disability, essentially a learning disability, and had been a very great provider for his family, and now was in his early mid 60s and was having some real significant cognitive impairment. And I was able to watch him. I watched the neuropsychologist interview for about 45 minutes, and then I went with the tech who did the tests that the neuropsychologist had ordered, and that took about 2.5 hours. And I just remember seeing how anxious he was. He was so incredibly anxious. You could see that he wasn't getting a good score on some of the tests because of his anxiety. And essentially, my theory was that he had some level of trauma is probably too strong a word, but school was really hard for him, and he carried a lot of baggage around being tested, and he brought all of that in to this neuropsych test. And then I wonder, when these things are scored by a neuropsychologist who is aware or may not be aware of the testing conditions or an anxiousness around something like being tested, I wonder how do you, or how does, some of the mentors or colleagues that you've worked with, how do they contextualize testing conditions, mood, and sort out what's an issue with attention, anxiousness versus this is really a problem that looks like cognitive impairment that may be the beginnings or you're in the throes of an Alzheimer's situation?
Yeah, that's a good question. And sometimes it's fairly obvious and easy to do, and sometimes it's really difficult. Typically, there are patterns on the neuropsychological testing. For example, looking at his learning curve and how that falls out, looking at his processing speed, looking at his self-report in terms of anxiety, and taking into consideration the contextual features of the interview. But sometimes it's really difficult to tease out. I think it's fairly easy to be able to differentially diagnose between full-on dementia or early dementia or mild cognitive impairment, but it would be much more difficult to differentiate between subjective cognitive impairment and a severe anxiety and learning disability such as that.
Oh, so you mentioned this word subjective cognitive impairment, which has made its way, as you know, into peer-reviewed literature and is drawing a lot of interest from pharmaceutical companies. And because these are the people you could theoretically intervene on very early and hopefully would get better before they slide down this glide path to much more brain damage and more significant loss of independence and things like that. To you, when we say the word subjective cognitive impairment, does that have a definition, and does that have classic features or characteristics for the people that you're seeing? And you could say, this is what they'll look like on a neuropsych test, or this is what they won't look like. And these are some of the things that you may be able to expect from someone with SCI, or subjective cognitive impairment. Do you understand the question? I asked the question in sort of a funny way, but really, what is SCI? And then what does it look like to a neuropsychologist? How does a neuropsychologist work with that or define that?
Yes, I think that term subjective cognitive impairment or subjective cognitive decline has been popping up in the literature and just in different venues talking about as a precursor to mild cognitive impairment, or a precursor, maybe the earliest clinical sign of Alzheimer's disease. And so, yeah, basically it's finding that this person may not have clinically significant impairment in terms of maybe they're still performing within the normal range or performing within what's called one standard deviation of the normal range, but they're not performing what would be normal for them. And so they're noticing some memory slippage, or they're noticing that they're not as sharp. They're noticing some word finding difficulties, but it's not quite yet to the point where we would really pick that up on cognitive testing.
So in your assessment, just to push on this a little bit more, someone comes in and they're smart, right? Whether they went to school or not, one indicator that they're smart might be that they completed a PhD in psychology. That requires some level of intelligence and achievement. So the regular tests for the regular battery of tests that you would do, or someone like you would do, may not pick those things up, but they know they're having a problem. Is there like a next step that they could do? Because my understanding right now is there really isn't a valid way to capture these people other than say, listen to what they're saying, which is, I know there's a problem. I don't care if your test shows it or not. I know there's a problem.
Yeah. So I think that kind of circles back around to having a cognitive screener versus a neuropsychological evaluation. And so if we're just giving a global cognitive screener, such as the MoCA, someone who does have subjective cognitive impairment is likely going to breeze through that. It's going to be pretty easy for them. In addition, they'll probably breeze through CNS vital signs without any red flags. For a typical neuropsychological evaluation, you're going to see some smoke before the fire, where everyone is going to have strengths and weaknesses. But for someone with subjective cognitive impairment, we would probably see more significant weaknesses on that sensitive cognitive testing. There are people who may be so smart that they're still able to perform really well on all of those cognitive measures. And I think, to make sure that there aren't other things that are impacting the test results, such as depression, such as anxiety, such as other things like sleep impairment or just distractibility or ADHD or something like that. But I think that we know that we can believe patients at this time if they're feeling like they have some subjective cognitive concerns about their memory, then I think that we would be doing them a disservice to say, no, you're fine, not yet, come back when there's a problem. I think, and there's been several studies that have been done showing that people with subjective cognitive impairment have shown that they have greater amounts of amyloid buildup in their brains than others. They're actually have a greater possibility of converting to MCI at a later time. So I think it's time that we really start to listen to people's concerns, and then with the knowledge that we have from functional medicine, start cleaning up some of those behavioral variables in terms of diet, exercise, things like that, to see if we could prevent or slow or stabilize or restore some of the cognitive function that they feel that they have lost.
Yeah, so you used the word prevention. I mean, that's a really interesting word now. Apparently, there was a shift in the second half of 2018. Dr. Richard Isaacson, whose work is well worth reading and checking out, was able to get his first journal article published in some journals that prior to that were waiting really for more robust evidence around Alzheimer's prevention. The analogies to Alzheimer's it seems very analogous to heart disease, in the sense that heart disease is something that people live with. It's treatable. If somebody needs a CABG, there's no bypass surgery, triple bypass surgery for Alzheimer's at this point. But hopefully there will be more heavy-duty interventions in the not too distant future. Of course, we've been promised those for a long time.
I'm not going to hold my breath, but hopefully. But
on the prevention side, I mean, you and I have talked about this in over the months and years in the past. This idea of prevention implies that people can live with Alzheimer's as a disease and can essentially identify it early, and have minimal effects of it and kind of go about their life, maybe not, like when they were 25, but would be able to continue a reasonable amount of life, a quality of life with a reasonable amount of independence. And that is a completely game-changing notion. I mean, do you buy into that? Because my reading and that's how I feel like things are going now. And I really feel like 2018, from the people that I talk to in traditional medical environments, not sort of functional medicine environments and what have you, it seems like that's now a conversation that you're allowed to have in the Alzheimer's Association parties. You know what I mean? Whereas a year or two ago, those conversations were still sort of taboo and you get laughed at.
Yeah, I think it would be looking at, or that you were creating false hope and that dementia is predetermined, it's your genetics or bad luck, and that, you'll just be walking along one day and this dementia diagnosis is going to fall from the sky. But I think we really need to start looking at this with a new approach. The way that we're treating brain health issues is too little, too late. It isn't working. We need a new approach. And this is one that focuses on prevention and resolving the underlying issues. And the research is really supporting that.
Yeah. So along those lines, so you've seen people that are very, very sick, and we would call that, moderate or later stages of dementia. And you've also seen people that are coming in for prevention assessments or early intervention. Can you speak to some of the things that you and your group have been seeing results-wise for people that are able to catch and do something about this early on versus what you're seeing with people that are in later stages that have lost their ability to be independent, may need a nursing home or assisted living or something like that?
Yeah, and maybe a couple of case examples might put some light on it. One of our patients inadvertently found out that she was a carrier of one of the APOE4 alleles. So she was E3, E4, and she didn't want to find out this information. It was, something through just genetic testing through a heart test that she did through Boston Heart Math. And so she was devastated by this. And I think that we need to educate a lot more that people are more empowered, and that just because you're a carrier of APOE, it doesn't mean that there's nothing you can do or that you're destined to get Alzheimer's. So she came in and was, very worried and was kind of just preparing for when she will eventually get Alzheimer's, but thought maybe there could be a few things that she could do. And she was 70 years old. We gave her the full cognitive testing, and she actually did very well. There were a couple of, smoke before the fire in terms of her processing speed was a little bit lower. Her animal fluency was a little bit lower, but everything was well within the average range. And she was a very bright woman. We looked at her biomarkers. Her homocysteine was very high. I think it was probably 19, like 16 or 19.
Wow.
Her inflammation markers like C4A was sky high. Also her fasting insulin was high. Her HbA1c was pretty high. And even though she was a very thin, small-framed woman, I think people equate being, at a normal weight, or even she probably was even slightly underweight, with being healthy.
Yeah.
But by her biomarkers, it really looked like, there was a lot that we could do in terms of behavioral interventions. She was a Southern woman. I'm here in Alabama, and, drank sweet tea, a couple times a day, and enjoyed her sweets, and just, really thought, well, I don't eat sugar, didn't really equate with, the things that she was doing with intake of sugar. Like she wasn't, dumping spoonfuls of sugar into her coffee, but, it was pre-made for her and wasn't really equating that, and ate a lot of processed food and ate a lot of omega-6s, like going out a lot, and the oils.
Oh, a lot of inflammatory foods.
A lot of inflammatory foods. And so we worked with her for about 9 months in terms of, she really did a 180 in terms of her diet and lifestyle. She started exercising. Her husband also just really embraced a lot of the changes. And we redid the cognitive testing 9 months later, and everything was improved, slightly improved, not significantly, but was improved, which is kind of unusual in terms of cognitive testing. Usually it's kind of, pretty much the same or it gets worse over time. And then her biomarkers were significantly improved. So her homocysteine actually dropped below 9. So I think in terms of that, and I think the peace of mind that it gave her as well is that I really don't think that she will develop Alzheimer's in her lifetime if she continues on this trajectory, that we could give her that empowering peace of mind that her cognitive test scores were right where they should be, with reducing her inflammation markers, reducing her homocysteine, reducing her HbA1c and her fasting glucose, and really reducing her risk for other chronic disease. She could really manage having the APOE4 allele, and it is very unlikely that, that we would probably be seeing signs of it, 10 to 15 years earlier. So it's really unlikely that she'll develop Alzheimer's disease in her lifetime. So I think that's one way to kind of look at, how you can look at prevention, because she came in and really wasn't having any issues, no cognitive problems. And now I think we're really preventing that from happening.
So cool. So that brings me to really one of my last question here is, for your projects, your research, and where you're taking your group, what are the most logical next steps to study that are achievable? I don't mean, a $100 million study. I mean, things that are possible for you and similarly aligned clinicians to need a research focus. I mean, what are the top 2 or 3 things that you see that are kind of next steps to move the agenda forward, to understand this better, et cetera?
Yeah, the research that we've looked at so far is looking at outcomes, again, just measuring cognitive test scores pre and post intervention, and measuring biomarkers pre and post intervention. And we were able to show that there's improvement happening, or at least stabilization, because some of our early patients were pretty far along on the spectrum in terms of dementia, but we've been able to keep them stable over time. And so I think just, continuing to flesh that out in terms of identifying what the specific biomarkers are, identifying what the most important cognitive tests are, and then what the most important, impactful, and doable interventions are going to be, so we can have all these lofty ideas, but at the end of the day, people have to make the behavioral changes or have to have the financial resources to do the interventions. And so being able to figure out what level of adherence you need to have and what are the most impactful changes that people can make to really protect themselves from a dementia.
Absolutely. Wow. Doctor, oh my gosh, Christine, thank you for being here.
Thank you.
It's so good to have you, one of us. You know what I mean? It's great. I'm always get excited about our conversations, and hopefully it won't be too long until we have our next.
I know. Thank you so much for having me. Thank you for the work that you're doing. And, just really am excited what the future holds in terms of, prevention for this devastating disease.
Yes, and of course we'll post how to find you in our show notes, but you just want to tell people that quickly?
Yeah, so I'm in Birmingham, Alabama, and I have the Brain Health Institute. We have a website at www.bhibrainhealth.com, and you can email me through the website.
Okay, excellent. Christine, thank you so much.
All right, thank you.
So that's our episode. I hope it was useful to you. Check out the show notes on iTunes or on our website where we've summarized the key points. If you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. If you have questions or comments, connect with us on social media. Finally, to support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show. That's Patreon, Patreon, patreon.com/evolvingpast. Thanks, and talk to you next time.